Hello everyone. My name is Dr. April Demito and I'm the Assistant FNP Program Director. I put together a Final Four review for Nursing 667 Acute and Episodic Care. The purpose of this is to give you a better understanding of the content of the last 4 weeks rather. It may help you narrow down the material that you are studying for your final. However, I can't stress enough that this is not intended to be your sole method of preparing for the upcoming final exam. So you would be making a mistake to think that. So this might help you to narrow down the material that you need to focus on, but it is not meant to be the only method you use to study. All right, so let's get going. Balance and the elderly. This is a big topic of concern in the geriatric population, and this is for several different reasons. In the geriatric population, gait and balance disorders can be problematic in that they may fall, their bones are much more brittle, they're more likely to have hip dislocations, hip fractures. So balance and dizziness in the elderly is very concerning. Also, we need to look at the characteristics of this of balance in the elderly. If a patient is having issues with balance but yet no vertigo, that's concerning. So we need to refer them to a neurologist. Balance issues without the sense of vertigo can be the result of a stroke or brain tumor. So that's something we're going to refer out. And when we have lack of balance with vertigo, we're going to worry about disturbances in the middle ear, like Meniere's disease and other issues that can cause vertigo. And here we go, vertigo. So it's often caused by ear problems. We can think of benign proximal positional vertigo. We see this more often in middle age, but as we age, those bones in the middle ear, which fit together like a puzzle, the puzzle pieces begin to come a little loose and they don't fit together as well. The dislocation of those puzzle piece bones can cause vertigo, so we need to advise our patients to get up slowly. Also, there is a whole host of exercises that we can have our patients do that suffer from BPPV. Meniere's disease, it's an inner ear disorder. They think that it might have something to do with fluid buildup, but it causes not only vertigo, but hearing loss and constant ringing of the ear. We have vestibular neuritis or labyrinthitis. This is in the middle ear as well. And it can also, less often vertigo can be associated with head or neck injury, but as I said previously, we need to rule out stroke medications and also migraines too. Now, essential tremor. Essential tremor is not like the tremor you see in Parkinson's. And when I have my patients, I talk freely with them back and forth. I have conversations with my patients. And I learned about essential tremor through conversation with my patient. I work in an acute care setting, so I don't deal with chronic issues. So when I found that the patient had essential tremor, I asked her about it. And with essential tremor, it is uncontrollable shaking in different parts or on different sides of the body, usually the hands, arms, heads, voice box, tongue, or chin. And only when the tremors become severe can it actually cause disability. And one of the interesting things with essential tremor, if the patient drinks like a glass of wine, the tremor gets better. So that's one of the things that kind of help differentiate it from Parkinson's disease. Also, if they have essential tremor, it's often treated with beta blockers. And so that may be something that we want to consider in these patients. Cluster headaches, they can occur in patterns called a cluster period. And with cluster headaches, they're quite intense. It can be one-sided, and these patients will often have tearing, nasal stuffiness, runny nose on just the one side. And the interesting thing about cluster headaches is that they can actually be improved by the use of oxygen. And I think about an interesting story. I noticed when I was in 7-Eleven the other day that they had canisters of oxygen by the register, and I was wondering what the heck they were using that oxygen for, but who knows, maybe the oxygen is used for people who have headaches. I don't know, but something to think about. It's interesting to see how migraine treatment has evolved over the years. I have had many friends and patients who have suffered from extreme migraines to the point where they've had to go to the emergency room for treatment. I mean, the migraines can last for days, and you can see, according to this photograph, the different phases of the migraine. I had a friend once who actually would lose vision in her right eye before she would get a migraine. And as treatment, they've come up with different treatments. And now a lot of neurologists are using epileptic medication, anti-seizure medication to control migraines. Off-label use of drugs happens a lot in medicine. So if a patient has nausea and their headaches are associated with weather changes, sleep patterns are disrupted, throbbing on that head, it's not uncommon for providers to prescribe a drug called rizatriptan. Many migraine sufferers will find relief with the use of that drug. Now, tension headaches are a little different. Tension headaches, patients may feel as though they have a band across their head, and it can be caused by stressful situations in your life. It can also be because you're tensing up. It can be caused by positional, being in front of the computer too long, bad body posture. They can cause nausea also. With tension headaches, we're going to try non-steroidal anti-inflammatories, muscle relaxants, and if they have nausea, we will try antiemetics as well. So those are 3 types of drugs that we'll use to help with tension headaches. There are other things that we can do too. It's kind of a hit or miss. Let's see how it works. Sometimes people are helped with massage, heat. So we have to be open to trying all different types of treatment in our headache patients. Trigeminal neuralgia. When patients experience this, they are going to feel spasms and burning shock-like pain on both sides of their face. And this can be triggered by chewing or talking. Now, if the patient experiences these types of symptoms, we're going to order an MRI. And anytime that we are suspicious of soft tissue issues, we have to order an MRI. And we want to make sure that it's appropriate, because most of the time patients have to get pre-certified for MRIs, but if we think it's warranted, then we need to do what we have to do to get it ordered. Okay. We see patients in our clinics that are suffering from panic disorder. And in managing panic disorder, a few things that we want to consider. Patients who suffer from panic disorder can be treated well, often, with SSRIs. They're one of the methods. We usually start out an SSRI on either 25 or 50 milligrams. 50 milligrams is the dose that we can go to for panic disorder. Over 50 milligrams is no longer going to be treating the panic. So typically patients who are suffering from depression will start out on a lower dose and ultimately end up on 100 or 150 milligrams of, I'm using Zoloft as an example, because that's a very common SSRI. So we start on these low dose numbers. So if a patient comes in and after 6 weeks of being on an SSRI and has not seen any improvement in their symptoms, at that point we need to refer them out because we're not psychiatric nurse practitioners, and this is going to be beyond our scope of practice and level of expertise. We don't want to just give the patient a benzodiazepine. It might help the anxiety, might help the panic, but now we have an addiction. So when our first efforts are unsuccessful, then we need to move them to the specialist. With PTSD, we have some options out there for us as providers, and typically these patients will experience nightmares, loss of appetite, difficulty concentrating, they isolate themselves, they may use drugs and alcohol. Those are all methods to try and self-medicate. If a patient comes in with these complaints, you need to have a conversation with them to see if you can identify what's going on, or what perhaps resurfaced. I know I've had patients who may have experienced things as a child that they were able to handle fine. However, as adults, when they have children of their own who are entering the age that they were when the event occurred, that they may, it may be a trigger, and they may begin to experience these things. Also, you know, we have our PTSD not only happens from crime victims, but it happens to soldiers and police officers. And possible treatments for PTSD can be your selective, your SSRIs, also the serotonin norepinephrine reuptake inhibitors, and tricyclic antidepressants can work well with PTSD as well. So we have some more options that we can use with this population of patients. Grief. Grief comes in many different packages. So some people react differently to grief. And grief, as in the stages of death, you go through the same types of stages. So there is no time limit to grief. Some people recover quickly. I remember when my father passed, after a month, my sister said, "Yeah, I think I'm okay." Well, my dad lived with me. I took care of him. I made his doctor's appointments. Our meals were planned on what he could eat. And I went through a grief process that took about 2 years. Now, I continued to function, so it was normal. And in the beginning, when people are experiencing grief, we need to let them know that what they're experiencing is normal. Sometimes patients will say, "I feel like they're still here." Sometimes with my dad, he smoked a pipe. Sometimes I thought I could smell his pipe. So all of those memories that they're feeling are normal responses to grief. It's when your grief begins to interrupt your normal daily activities and you are no longer able to function, that it becomes problematic. Okay, suicide risk assessment. When I was preparing for this presentation, I did some research on suicide risk assessment, and there are so many resources out there. Now, once you are out there and practicing, I think it's important for you to see what resources your employer has for you. If there aren't any readily available, then I want you to get online and find one that works for you. The best way to research tools is to go, first of all, CDC is my favorite site for everything. Then you may want to go to professional organizations and see what resources they have as well. I love the American Association of Family Practice Physicians. It's a great site. And there are some patients, we always have to be cognizant of the risk of our patients, but patients that are going to be at an increased risk are those who are suffering. They have weight loss. They're not sleeping well. They are beginning to have, it's beginning to interrupt the normal family dynamics. At that point in time, I would do a suicide risk assessment of the patient. And I've had people say to me before, well, okay, what if you think that they're at risk? Well, you have to do something about it. As a healthcare provider, you are now duly obligated to act on patients that you are fearful may harm themselves or someone else. Lithium. Lithium is a great drug. I can remember when lithium first came out, and it's known for working really well. It's a mood stabilizer, so it works really well on those who are experiencing the signs of bipolar disorder. And those who suffer from bipolar disorder, there are all different types of levels now that we've identified, but they may have extreme highs, extreme lows, difficulty concentrating, erratic behavior. So you might see, that's the patient that, I think that one commercial says it beautifully, where the person's outside cutting down a tree in the middle of the night. So it wouldn't necessarily be an abnormal thing if it weren't 3 o'clock in the morning. So lithium works really well for stabilizing those moods. Now, it's not without side effects. And the thing with lithium, there are other drugs out there now too, other mood stabilizers, but lithium can cause weight gain. It can make you tired. So the problem with these psychotropic drugs that we use in our mentally ill is that often the side effects are to the extent where it makes the patients not want to comply. So they may feel, okay, I'm feeling better, but I'm tired and I have gained 25 pounds. I think I'm going to stop taking it. And then over a period of time, the symptoms all come back. Lithium is one of those drugs that you need to check the patient's level of, because you need to reach a therapeutic level and before it is effective. All right, now we're going to move over into joints and bones. Now, signs of a bone infection. Those of you who have any experience in orthopedics know that this is we don't want people to get bone infections. Bone infections are very difficult to treat. The patient who has a bone infection is probably going to be on IV antibiotics for weeks or months if we can ever get rid of the infection. So very worrisome with these bone infections. What sets bone infections apart from cellulitis, for example? Well, cellulitis is an inflammation of the skin. The patient presents with swelling, warmth, firm area of the body. And sometimes those patients need to be sent to the emergency department for IV antibiotics because it is to the extent where oral antibiotics just aren't going to do it. But what sets bone infection apart from those cellulitis cases is that this redness and tenderness is in a joint. So if we have a patient who presents with swelling over a joint, it's red, it's warm to the touch, they're going to go to the hospital. You're going to send them to the ED because they need IV antibiotics. Bursitis, this is an inflammation of the bursa, and it can happen in any joint. You see this in the knee, in the elbow, in the foot. Usually the first intervention is activity modification and bracing. So a lot of people will wear those, they've got some great devices out now, compression things that will help a lot with bursitis. Sometimes patients actually need to have an injection, a steroid injection to help with that. The bursitis is that chronic inflammation. Usually the first thing that we're going to do though is rest, and we're going to use pads to protect the area, non-steroidal anti-inflammatories, rest, and ice. So that's usually what our first line is with bursitis. Gout. Gout is an incredibly painful disorder. And we see this is actually an accumulation of uric acid crystals that form in the small joints of the body. Typically, when I first started thinking about gout, I thought, oh, the great toe, that's where it goes. And that's the most common spot. But it can also go in the ankle, it can go in the wrist and the hands. Elevated uric acid can cause the deposition of these crystals throughout the body, and it's incredibly painful. We usually will treat it with non-steroidal anti-inflammatories like indomethacin. That's one of the drugs we use. But we need to consider how the patient's renal function is. Because remember, non-steroidal anti-inflammatories don't like the kidneys. And patients with gout go on pretty high doses of non-steroidals. So if you have a patient with impaired renal function, you might want to consider an administration of intra-articular steroid to help. Because we are not going to be able to use steroids. I mean, not be able to use anti-inflammatories. Sometimes we'll give oral prednisone, but it doesn't have the quick acting, I'm just looking at something. It doesn't have the quick action that this injection will have. Postmenopausal hyperuricemia. This is high level, and it can happen in advanced age. So I wanted to talk about hyperuricemia, not just in the postmenopausal woman, but in patients across the board. So if the patient is experiencing gout, it generally happens for a couple of reasons. Patients who have diets high in purines, which are organ meats, meat, beer, alcohol. Now, sometimes patients experience gout, not because of their diet or their lifestyle, but because their body is not excreting uric acid the way it should. So patients who are not excreting uric acid the way they should will experience episodes of gout. without having any of those dietary influences. So with patients who have gout, I strongly suggest those patients have a 24-hour urine done. That urine is going to look for uric acid. Now, if the 24-hour urine is low, then that means the kidneys are not excreting urine or uric acid the way that it should, and then we may need to intervene by prescribing medications like allopurinol that are going to reduce the levels of uric acid in the body. And you can find really great relief by using allopurinol. But again, unfortunately, you cannot use allopurinol in patients who are compromised in their kidney function. So we'd have to work on something else. The anterior drawer test. This illustrates how to perform this exam, and we're looking for ACL issues. Lumbar pain. Lumbar pain is actually one of the most common complaints that causes issues or why people come to seek medical care. And it's interesting, when we have this low back pain, we don't necessarily want to just throw opioids at them, right? Because now we've got this huge issue of opioid addiction. But we will try is we're going to use first line, we're going to use non-steroidal anti-inflammatories. And we're also going to use things like Valium, benzodiazepams will work pretty good when we have patients. Now, if we have a patient who has had this long-standing pain and it is no longer working to help with the pain management, then we're going to need to consider implementing opioids or narcotics, but not as a first line. So we're going to consider that if there hasn't been any relief. But first and foremost, we're going to work on, that's going to probably be the third option. We're going to try non-steroidal anti-inflammatories, physical therapy, so interventional medicine, so a interventional spinal medicine, which I think they have some really great subspecialties out there for lumbar pain that they didn't have to do. But I think the key here is we're not going to jump to opioids, not at all, not anymore. Conservative management is typically what we're going to do. Osteoarthritis in the knee, and these are the different stages. And we have lots of patients who have osteoarthritis as they get older, so we need to identify these patients and start treatment early. Now, there are many medications. We have to differentiate osteoarthritis against rheumatoid arthritis. We need to identify the differences, because if it's rheumatoid, there are lots of treatments out there that can help now with that, like DMARDs. And DMARDs are not indicated in osteoarthritis. What are we going to do? We want these patients with osteoarthritis in the knee to do low impact aerobic exercise. So this is not the patient that we want to be doing running. The best exercise for people with osteoarthritis is non-weight bearing aerobic exercise, like an elliptical, recumbent bike. Those are great methods to help keeping it mobile. So you have to keep moving that joint, because we don't want that joint to get locked. And steroid injections We can use these in lots of multiple joints. I just had one in my shoulder last week, actually. And when you're doing these steroid injections, it's important to do a lot of teaching. Now, it might take up to 4 days for you to get full relief if it's going to work. And the patient may notice some initial worsening of the redness due to the injection, but after that they should notice the improvement after a few days. Now, RICE stands for Rest, Ice, Compress, and Elevate. And when we're using this rest and ice and compression, the compression, you can use an ACE bandage. ACE bandage works well, and it also gives some support to help with being able to stand and walk. So it helps a lot in being able to be mobile. Sprain grading. So you should have a good understanding of how to grade a sprain. I don't see this in my practice. This is a patient that I would send off to emergency, only because I don't have the capacity to x-ray it. So if I have a twisted ankle, I'm going to want to do an x-ray on it just to identify whether or not there's anything broken in there. Okay. Now, performing a McMurray test is something we're going to do on with knee injuries, and it's positive for a torn meniscus if you can palpate or hear a click when you're rotating and extending the knee. So these are all procedures I'm sure you learned when you were in your advanced health assessment course, but now you're actually going to be applying it. Okay, so now we've moved past musculoskeletal, and we're going into the GI. And common bile duct obstruction, this can occur for several reasons. The most common is a gallstone. So the gallbladder is this sac that holds bile that is made by the liver. And the gallbladder contracts and squirts those bile salts into the small intestine after people eat, and it's part of the digestive process. Unfortunately, sometimes those gallbladders can fill with stones, and these stones are actually rocks. If the patient has a gallstone, not only does it cause pain, because imagine you have this sac, it's like a balloon, okay? The balloon contracts, and it contracts around these sharp stones, and it elicits pain. It's not contracting completely because it's not able to. The sac is filled with stones, so you're going to end up with digestive issues. Sometimes these stones dislodge and end up in the common bile duct, causing great pain. It can even actually cause pancreatitis due to becoming lodged in that bile duct. So lots of things to consider. Upper right quadrant pain often is gallbladder, not exclusively. If you have abdominal pain and you can see pulsations and you can feel a bump, I am thinking a AAA, and I want that patient to go to the emergency department. So remember, as nurse practitioners, one of the things we do is worst case scenario. So if I have a patient, I'm thinking about my differential diagnosis. Well, if they're having upper right quadrant pain, a AAA is going to be on my list of differentials. Sometimes patients with this bile duct obstruction, it can cause nausea, vomiting, and yellowing of the skin due to buildup. Okay. And here is a picture of the gallbladder and how it works. And when the surgeon removes a gallbladder, Actually, they connect that duct to the small intestine, so the bile is going directly into the small intestine as opposed to being held in the gallbladder. Now, diverticulitis are these little pouches that occur in the large intestine, and it happens not uncommonly in patients as we get older. Some people are more prone for them than others. They may be asymptomatic where they don't cause any issues whatsoever. And there are other patients where they can cause great pain and inflammation. With inflammation, can even cause infection to the point where they need to have a resection of their intestine. So if we see a patient that we think has a colonic diverticulitis, and we were contemplating doing imaging, a CT scan is what we would order on this patient. If we have a patient who's experiencing left-sided pain and they have blood in the stool, I'm going to refer for a lower GI. So lots of things to consider when we're ordering tests, and I think that perhaps as a nurse practitioner, one of the things we need to work on is identifying when it's appropriate to order tests and when it's not appropriate to order tests. We don't want to get crazy with ordering tests, but we also don't want to not order those tests. Polyethylene glycol. I wanted to show you a picture of this because this is commonly used in people who suffer from chronic constipation. And what's good about this one is it's non-habit forming. So if you're using a regular laxative like X-Lax, your body can become adapted to it and you won't be able to have a bowel movement without it. So the good thing about this is that it's non-habit forming. I have patients that use this long term, so, and especially in the pediatric population. So they may use this every day because they suffer from chronic constipation. Okay. And this, if you see this in the store, this is Miralax. In order to diagnose a patient with recurrent constipation or chronic constipation, they must meet the Rome 3 criteria, and that includes 2 or more of the conditions listed here, and then also loose stools are rarely present, and they then have insufficient criteria for irritable bowel syndrome as well. So that's how you diagnose a patient with recurrent constipation or chronic constipation. Okay. There are different types of diarrhea too. It can be caused by food poisoning, traveler's diarrhea, stomach flu, which isn't the flu at all. Chronic diarrhea can come from celiac disease, food intolerances, IBS, and different medications. If you have a patient that suffers from acute diarrhea with moderate dehydration and bloody stool, I want them to have a stool specimen. I need to rule out E. coli. I need to rule out C. diff. So those are all things I'm going to consider in my diarrheal patients. Have you been traveling outside of the country in the last month or so before you had diarrhea? Traveler's diarrhea is a big one. So if they're suffering from traveler's diarrhea, they're going to be put on Cipro for 3 days. Gastric surgery and diarrhea. So anybody who has had surgery on their GI tract runs the risk of having diarrhea or dumping syndrome. And that can be with gastric bypass surgeries or patients who have had part of their stomach removed due to cancer or ulcers. And with dumping syndrome, it's very uncomfortable because about 30 minutes after they eat, all of a sudden, bam, they have to go to the bathroom, and they may have undigested food. The best way to help prevent this is to not drink fluids when you are eating, which would be very difficult for me, but for other people it's not. So not drinking fluids with meals. GERD, this is another really super common occurrence in our population of patients, and that's gastroesophageal reflux disease. There are certain risk factors that will promote this, such as obesity. That's one of the things that it can cause pain. And the best way to diagnose this is using an endoscopy. Also, while you're doing that endoscopy, the physician is going to do some biopsies to rule out H. pylori and also to rule out Barrett's esophagus. So these patients are routinely treated with PPIs, proton pump inhibitors, or H2 inhibitors. Now we're finding some problems with these things. We found now I'm trying to think, when did proton pump inhibitors have been out? Probably for 30 years, I want to say, or maybe 25 years. We found now that they aren't so great because the body, you can develop stomach cancer, and the H2 inhibitors like Zantac, they inhibit the secretion of hydrochloric acid from the parietal cells in the stomach. Sounds wonderful, but the body will create new cells to excrete the hydrochloric acid. There's a lot of talk in the news today about Zantac, and I think it's a misnomer. It's actually the inert ingredients that are concerning. It's not the use of Zantac it's the material that the tablet is made out of has been contaminated. So that's been pulled off the market. There are good things and bad things about everything. So if someone is troubled with GERD, I advise them not to watch their diet, find things that work and don't work. The best thing to do is to start with a food diary, so that you can see what foods cause an increase in your symptoms. I know for me, if I eat a raw green pepper, forget it. It's very painful. I'm going to end up with problems. So a food diary is number one. Then if you're going to start using drugs, you may want to alternate the use of a PPI and H2 inhibitor. So you can switch those off. You also have to rule out infectious esophagitis. So with infectious esophagitis, patients will experience sharp pain with swallowing right under the sternum. So you need to differentiate that from GERD. Also, what's going to increase GERD? Lots of drugs. Aspirin, of course. Aspirin, non-steroidal anti-inflammatories. They are antiprostaglandins. Now, prostaglandins cause you cramping when you're in your menstrual cycle, and also prostaglandins are in the stomach. It actually creates a lining that helps to protect the stomach from the stomach acid that is secreted. So if you're using aspirin and nonsteroidal anti-inflammatories, it reduces the prostaglandin in the stomach and increases your risk of developing stomach ulcerations and GERD. Benzodiazepams and calcium antagonists are also culprits for increasing your risk of GERD. Peptic ulcer disease. Typically, the symptom for this is going to be epigastric pain that occurs about 2 or 3 hours after eating. So, there are a lot of things we're going to rule out. We're going to rule out gallbladder. But the best thing we can do is to do that endoscopy and get a biopsy to rule out H. pylori, because H. pylori is the culprit that causes peptic ulcers. And we're going to use 14 days of clarithromycin and a PPI to get rid of that. So 14 days. Esophagitis, you can see a healthy esophagus and then one that is not healthy next to it. The one next to it has Barrett's esophagus, which is precancerous, and not a good thing. So endoscopy can identify these patients that are maybe at risk of developing esophageal cancers, and then we would medicate these patients as needed to get rid of that. There are also things they can do. I've had patients that have come in and had their esophagus radiated to get rid of the Barrett's esophagus. I had 2 patients that described the process to me. They said it was incredibly painful because essentially what they're doing is burning the inside of your esophagus. But it got rid of the Barrett's, so it greatly reduced their risk of developing esophageal cancer. Irritable bowel syndrome, another common event. This is fluctuation between constipation and diarrhea, and important factor in trying to maintain IBS is, again, food diary and high fiber diet. You want to be careful, with your high fiber diets, because if you have diverticulitis, you want to eat high fiber, but you want to avoid fibrous foods like corn and nuts and seeds. Those things can actually get into the little diverticular sacs and cause issues. Okay. And this little slide, I don't know why I put this here, but it's another slide of H. pylori. Traveler's diarrhea, talked about 3 days of Cipro, usually we'll take it. Sometimes you need to use a Flagyl too, but usually just that 3 days is enough. Incontinence, a major complaint of women as they get older. Men too can suffer from incontinence. The different types of stress incontinence, and overflow, urge, and neurogenic. This is neurogenic incontinence is due to spinal issues, paraplegics, any issues with the spine. So there's no nerves telling you that your bladder's empty or full. Overflow occurrences can be due to blockages or strictures in the urethra. Urge incontinence, involuntary contraction of the bladder muscle, and we will use antispasmodics specifically for that. Stress incontinence is super common due to increased abdominal pressure, due to weak pelvic floor muscles. I was involved years ago in an incontinence study. I was actually helping to gather data for Loyola University. And we found from, well, I won't say I just gathered data. It was the people who actually looked at the data. The study was talking about whether pregnancy, delivering vaginally or C-section increased the risk of incontinence. And actually the research study found that it wasn't the whether or not you delivered vaginally or C-section that increased your risk of incontinence. The fact that you were pregnant, period, increased your risk of incontinence. So that was pretty interesting. Hematuria in our patient population. Also I wanted to talk about people who suffer from incontinence. You want to get them, you want to work on them for bladder training. So a patient who's incontinent, go to the restroom every 2 hours, and that's going to not ensure, but it'll help reduce the risk of having an incontinent issue. Now, hematuria. This can be benign and not a big deal, or it can be a big deal. Now, in men, we consider hematuria to be, it can show, it's one of the first signs of bladder cancer. Now, in women, hematuria without a urinary tract infection is also a sign of bladder cancer. So it's very important, if the patient has blood in their urine and they do not have a urinary tract infection, that they be followed up to ensure they don't have bladder cancer. Now, if a woman comes in and she has urinary tract infection with blood in her urine, and subsequent urinalysis does not detect blood, it's not a concern. So it was caused due to the urinary tract infection. So we aren't going to worry about that. Now, lots of things to consider when we're talking about urine and urinary tract infections. There are complicated and uncomplicated urinary tract infections. So a woman comes in, she doesn't have any risk factors, she has a urinary tract infection, uncomplicated. A man comes in, has a urinary tract infection. Men are always considered complicated urinary tract infections because it's not a super common occurrence for men to get bladder infections, because the urethra is long and it does not pose such a threat to the bladder as the woman's short urethra. Pregnant women automatically puts them in the high risk category, so it's considered a complicated urinary tract infection. If we have a patient who is experiencing symptoms of a urinary tract infection, I want to get a urine culture on them, because I want to identify whether or not a patient is not only truly does have a urinary tract infection, but I want to check the sensitivity to ensure that the medications we're using are going to work. Now, the most common medications used in urinary tract infection are Macrobid, Cipro, and Bactrim. Now, Macrobid is a great drug. I like it. It works well on bladder infections and nothing else. However, if you have a patient over 60, it's not well tolerated. And if you have a patient who has signs and symptoms of a potential kidney infection, you don't want to use it because it does not work on the kidneys. So if we have a patient who is experiencing back pain, so that's one of the questions you always ask a patient with a urinary tract infection: are you having any back pain? If they say yes, they're having symptoms of back pain, you are not going to use Macrobid. You're going to have to use Bactrim or Cipro. And this slide illustrates some of the symptoms of urinary tract infection. It can be pain. I've even had patients that have just come in with the complaint of strong smell. In the geriatric population, urinary tract infection can cause confusion. So that's something to think about, that if you have an older person that is coming in with signs and symptoms of urinary tract infection, or signs of confusion, you may want to rule out urinary tract infection. Erectile dysfunction. If you have a patient who comes in with symptoms of erectile dysfunction, you definitely want to consider the underlying cause. Do they have cardiovascular disease? So those things all have to be ruled out. And if they don't have any of those symptoms, or they don't have any of those conditions, then it would be safe to prescribe a medication like Cialis. A variococele is a, it actually can feel like a bag of worms. That sounds gross, right? But when you're doing your examination and men, part of the examination when you're doing an annual physical examination is to do a scrotal check and prostate exam. But if a patient comes in and their predominant symptom is something has changed in my scrotum, it feels funny, what you're going to feel is if it's a variococele, I can't talk tonight, it's been a long day, their scrotal sac is going to feel like a bag of worms on one side, and you're going to send them to urology. Cremasteric reflex. With these patients, we're going to take our gloved hand and go up the side of their thigh, and this reflex, you can use a tongue depressor too, will cause the testicle on that side to elevate. So that's a normal occurrence. Renal stones. Renal stones are incredibly painful, and you can see that they're primarily comprised of uric acid. So if you have gout, you're at an increased risk of developing renal stones. Gonorrhea in men is the problem with sexually transmitted infections is that most of the time in women they're asymptomatic. The one thing I want you to be mindful of is if a patient is suffering from gonorrhea, we're always going to treat them for chlamydia. So we're going to use cephalexin injection and then 1 gram of Zithromax. That's the treatment. So even though they don't test positive, or haven't tested them for chlamydia, we always are going to treat them as if they have chlamydia. I hope that you find this presentation helpful, but remember, the most important advice that I can give you when you take your upcoming exam is to, number one, make sure that you take your time. You are allotted quite a bit of time to take your exam, and I find that those who do poorly have taken the exam quickly. Make sure that you read your test questions completely. You want to ensure that you're answering the question that's being asked. Another error I find is that sometimes students think too much. I'm terrible at that. I always do that. So try not to overthink the question and answer exactly what it's being asked. Look for words like always, except, so you know, or all that apply. If the question says answer all that apply, we know that there are at least 2 correct answers, right? Most of the time. Don't change your answers. Most of the time, your first instinct is correct. So, before you change an answer, make sure that you're 100% sure that that answer was answered incorrectly the first time. So I hope that you found this presentation helpful, and good luck.